Hi everyone, my name is Elise Lopez and I am here today to present my case study for Nursing 321 Pathophysiology. This presentation revolves around patient GW and the pathophysiology regarding his diagnosis of end-stage renal disease, or ESRD. ESRD, which is also known as kidney failure, occurs when the kidneys are unable to completely function due to permanent damage. So various health problems cause ESRD, such as chronic diseases or infections, and these damage the kidneys over time, which cause ESRD. And according to Benjamin and Lopin in 2020, diabetes mellitus, or DM, is the leading cause of ESRD, closely followed by hypertension. And our patient, GW, is a 59-year-old African American male who has a history of type 2 diabetes, or DM2, hypertension, hyperlipidemia, and dementia. All of these diagnoses help attribute to his diagnosis of ESRD. The patient's dementia prevents him from being able to care for himself properly, such as manage his diabetes and take his medications to control his hypertension and hyperlipidemia. This is confirmed during interactions and assessment with the patient, as he can only follow one-step commands and is only alert and oriented most of the time times one. He can verbalize things such as hi, thank you, yes, no, and okay. When you call his name, he may or may not answer sometimes. That's why I say he's alert and oriented times one. Because of these factors, the patient's sister, who can no longer care for the patient, decided to place him in a skilled nursing facility so that he is able to receive the proper care that he needs. So as we mentioned before, DM is the leading cause of ESRD. And when this disease is not managed, it ends up damaging the kidneys, permanently resulting in ESRD. Hyperglycemia creates a hard time for kidneys to filter out excess waste and fluid from a person's body. And the kidneys must also create extra pressure due to atherosclerosis in a person's blood vessels that's created from hyperlipidemia. That excess pressure to filter, added on top of the person's hypertension already, creates this tremendous pressure on the glomerulus of the kidney. And then over time, it damages the glomeruli, deeming it dysfunctional to filter out any excess waste and being able to reuptake all the important minerals, electrolytes, and red blood cells. This is why when you look at someone who is a patient of ESRD, you would see protein and some red blood cells, or RBCs, in their urine. So loss of protein from the blood vessels into the urine also results in third space movement, as there's no longer any protein in the blood vessels to keep that oncotic pressure. And these extra fluid end up creating this third space movement. And then you can see this when you do the pre-assessments or any kind of assessments on a patient, as you would see swelling in their face and their extremities, such as their arms, their hands, their legs, and definitely their ankles. As the patient is unable to excrete excess waste and fluid, they would experience signs and symptoms such as shortness of breath. You would hear crackles in their lungs bilaterally. You would see the swelling in extremities, like we talked about earlier. You would also see them be fatigued, be drowsy, have dry, itchy skin, but that's due to a high level of phosphorus as well, since they can't really excrete that. They would also experience headache, nausea, vomiting, ammonia breath, and anorexia due to the ammonia breath that they are experiencing. So different kinds of tests that we use to perform and confirm this diagnosis. We do a urinalysis, and this can tell us a lot of different things. Like we said before, this can tell us whether there's protein present in their urine, whether there are RBCs present in their urine. Another one for a urine test is the 24-hour urine creatinine clearance test. And this determines how much urine they're making in a 24-hour cycle, as well as if there's any creatinine present in their urine. If there is, for men, it's about 97 to 37 milliliters per minute. So if they are within that range, then that shows us that their kidneys are able to filter out waste. But because the patient's result that there is little to no urine, and his urine creatinine is low, it shows us that he cannot make urine, little to no urine, and that his kidneys are not working. So then we also look at his blood work to confirm this diagnosis. So different things that we look at are his serum creatinine and his blood urea nitrogen. And if these two are high, then it also shows us another reason that, or another thing that lets us know that the kidneys aren't functioning. Another one that we look at is his GFR, or the glomerular filtration rate. And if that's low, again, it shows us that the patient's kidneys are not optimal to function. Trying to locate other kinds of tests for this patient and his history and files, I was not able to see any other ones that confirm it. So I was basing everything on his lab work and the urinalysis that I found. So current evidence-based treatments for this disease have two options. One is dialysis and the other one is a kidney transplant. In 2015, Gadarian Hayati, Shayanpur, and Baladi Musavi did a study that resulted in statistics showing that long-term survival rate is much higher among diabetic transplant recipients compared to those patients that are on dialysis. So in order for someone to be on a wait list, hold on. Okay, so in order for someone to be on a wait list for a kidney transplant, they must go through different kinds of tests and evaluations to ensure that they will have a successful life after having the transplant. So certain things, this includes a full evaluation by the transplant team that is at the transplant facility. They also have to adhere to their current dialysis treatment, so they have to show up every treatment and stay for the entire treatment. They also have to have their blood pressures within certain parameters. They also have to adhere to every single medication regimen that they are prescribed to. They have to test negative for any bloodborne diseases. They have to have healthy organ function, such as their liver, their lungs, and their heart. They also must not have any other health issues, such as any untreated mental issues or any alcohol or drug abuse. So moving forward to the other option is dialysis, and there's two actually different modes. One can do a peritoneal dialysis, which is a catheter placed in your abdomen, and you can do this at home. And there are PD nurses present in the clinic that we meet with about weekly, just to check in and see how you're doing. And the training is very particular for it, and it takes a really long time. And the other one is hemodialysis. So you can do hemodialysis at home, or you can come to the in-center. And most people who usually do the at-home dialysis ends up coming to in-center hemodialysis 3 months after they started. So in-center hemodialysis treatments is about 3 to 4 times a week. Anywhere from 3 to 6 hours. Like we said, it's all based on a person's blood volume and how much we have to clean. It only cleans about 15% of a person's blood. It only functions about 50% of what a kidney does. We highly recommend and encourage patients to show up to every treatment and stay for the entire treatment. So what happens is that we use a dialysis machine. We call it an artificial kidney that pretty much filters out all the waste and excess fluid that a patient has circulating in their system. And each patient has a different prescription, such as the size dialyzer they use, a special bath. We usually use a 2 potassium 2.5 calcium in our clinic. But if they have a really high potassium, say like a 7, then we would use a 3 for their potassium bath. So it would be a 2 calcium and then a 3 potassium. We also do different kinds of temperatures. So we normally do 37 at the clinic, but if someone comes in with a low blood pressure, then we would typically put their dialysate temperature, what temperature their blood would be returned back to them. It would be at a lower rate. That way it constricts their blood vessels, and then it boosts up their blood pressure. That way they don't bottom out. The other way would be to if their blood pressure is extremely high, then we set their temperature to be high, and the highest we usually go is about 37 degrees Celsius, and that'll help lower their blood pressure by dilating their blood vessels. Like we said, the treatment time is based on the blood volume. Other things that we do to help replace kidney functions has to do with the endocrine functions that a kidney has. So we administer epogen to help increase red blood cells. We also give hectorol, which is the synthetic form of vitamin D, as the kidneys are no longer able to regulate calcium in the body. And we also give venifer iron sucrose, which helps with the patient's anemia status. And since the body is unable to regulate the blood pressure due to lack of function from the kidneys, like we said, we help it with monitoring the temperature that the patient has, and we also check their blood pressure every 30 minutes. Other ways we can do it is we work with a dietitian to help create a plan of care that's beneficial for the patient. This can include limiting the amount of sodium that they take in, or their fluid intake, or limiting certain foods such as those high in potassium, since the body can't excrete that extra potassium, and that would greatly affect the heart. We also encourage them to exercise often and make sure that they take their blood pressure medications as prescribed. Expected treatment outcomes and prognosis are generally good if the patient follows a treatment regimen that we have for them. But like we said, for the patient that we discussed, it's a little different since he has certain things like his dementia where he's not able to care for himself. So he's heavily reliant on other people to do it for him. Since he's in the care of a nursing facility, we can work with that facility to ensure that he is following his treatment regimen. From his lab results that we pull every month, we know that the facility is taking great care of that aspect since his electrolytes are all within range. The patient also attends every treatment and stays throughout his. So, hold on, lost internet connection. Okay, the patient attends every single treatment. Okay, so since the patient is unable to follow a two-step command and he's only alert and oriented times one, he gets cannulated on his upper right arm. So there's two needles that stay on there. He sometimes bends his elbow, so we have to keep telling him, please keep your arm straight, please don't move it, keep your arm straight, keep your arm straight. And so that his access arm won't be damaged at all during treatment. This also puts the patient at risk for hypotension due to blood loss that he would experience if the needles came out. During pre-assessments, also, the patient's lungs are almost always diminished bilaterally, and his blood pressures are usually about 185 to 190, or 185 over 95, I'm sorry. This shows us that he's not following his limited fluid intake and taking in more than he should. So nursing care for this patient would include putting him in a treatment station right by the nurse's station. So there's always someone that's able to keep an eye on him and make sure that we are keeping the patient safe and that we are able to see his access and the needles that are on his arm that'll prevent any kind of blood loss from happening. We also want to monitor everything he does every 30 minutes just to see where his blood pressures are at. So another would be to have a communication sheet with the nursing facility that would have his pre, intra, and post vitals and weight, and that way that we can kind of communicate on what the patient needs, how much fluid he can take in, and then that way they can also send us with a communication sheet letting us know what he's had for the day, how much fluids at what time, maybe there's something we need to cut back on, and maybe other foods that he's taking in that has a little too much water. So appropriate patient family education would just to family education would just be to let his sister stay informed throughout any kind of changes we try to implement in the patient's plan of care, and then also getting her input as to whether this might be a good plan. Should we do this? Is there something that we need to change, or can we do something different? That way that they would feel that, that the patient is part of helping to plan their care, even though he's only alert and oriented times one. So in conclusion, a patient's prognosis and treatment path can highly depend on what their status is. If they follow their treatment regimen and can properly care for themselves and show up to their treatments, then they would be highly considered for a kidney transplant, which would provide them with a way better better way of life than they do now. They wouldn't have to come keep coming to treatments 3 times a week. But if they are in the same situation as the patient that we mentioned above, then the patient would require tedious routine checkups and relentless communication between the healthcare providers and the patient's family so that we can care for this patient in the best way possible. Thank you so much.